presentation. And it's now time to welcome Dr. Hisham Hamdan, who's a pediatric pulmonologist at the Jalila Children's Specialty Hospital. He'll be talking about the home non-invasive ventilation for pediatrics. Welcome, Dr. Hisham.
Thank you. I'd like to thank the organizing committee for inviting me to present in this conference, and I also would like to thank everyone for being here. Today the topic I'm presenting is about home non-invasive ventilation in pediatrics, or LT-NIV, long-term non-invasive ventilation in pediatrics. I have no conflicts of interest. The learning objectives of this presentation is define what's meant by LT-NIV in pediatrics, what the equipment's used, the complications of using LT-NIV in pediatrics, some specific points about using long-term non-invasive ventilation in pediatrics with certain conditions such as neuromuscular conditions, cystic fibrosis, scaphosponsdylosis, OSA, and some challenges to use of long-term non-invasive ventilation during the COVID pandemic. The definition of long-term non-invasive ventilation in pediatrics is somewhat controversial. One definition is delivery of intermittent positive pressure ventilation in a child via non-invasive interface lasting for more than 3 months. Another one is administration of ventilatory support without using an invasive artificial airway, with other words, without using a tracheostomy, for 6 hours per day for more than 3 weeks. This is the most current definition of long-term non-invasive ventilation in pediatrics. Some people consider high-flow nasal cannula and CPAP as part of non-invasive ventilation in pediatrics. Some people don't consider CPAP or high-flow nasal cannula as non-invasive ventilation, and they make the non-invasive ventilation exclusively for modalities that apply biphasic pressure respiratory cycles, such as BiPAP. However, regardless of the definition, I think I would rather go by an objective-based definition. So if the objective of the intervention, the non-invasive intervention, is to overcome upper airway obstruction, control hypoventilation, reduce work of breathing, manage central apneas, or improve the patient's sleep consolidation and improve gas exchange, then I would define that as a modality of non-invasive ventilation. So those are kind of the objectives of non-invasive ventilation. Overcome obstruction, improve gas exchange, oxygenation, and CO2 removal, reduce the work of breathing, and manage central apneas, and improve the quality of sleep. So what are the aims of non-invasive ventilation in pediatrics? So the first aim is prolongation of life, and this has been shown in patients, especially in patients with neuromuscular conditions, that the application of invasive ventilation long-term, whether non-invasive or invasive, does prolong life. Improvement in quality of life, allowing for home care, which is also part of improvement quality of life, reducing the number of hospital admissions, and the quality of life score. One study showed that quality of life score in patients with Duchenne muscle dystrophy who are ventilated non-invasively and invasively is reported to be equivalent to that of the general population. So when you look at the trends in long-term invasive versus long-term non-invasive ventilation in pediatrics, and long-term invasive ventilation in pediatrics means tracheostomy and ventilation. So pediatric long-term ventilation have been increasingly reported. So the long-term ventilation in itself has been increasingly reported. Now, the non-invasive ventilation is become now preferable whenever able to use, and whenever there are local resources to use non-invasive. It's been preferable over invasive ventilation in recent years. However, most children receiving long-term ventilation are still ventilated via a tracheostomy. So the trend is towards more non-invasive ventilation. However, it's still the invasively ventilated children are more than non-invasively ventilated children. So what are if you compare them, what is the advantage of using invasive ventilation, meaning tracheostomy and vent, over non-invasive ventilation? So long-term non-invasive ventilation prevents tracheostomy-related complications, such as airway block with secretions or something else, decannulation accidental, which is an emergency, tracheal injuries that can lead in the future to like tracheal granulomas or tracheomalacia, and respiratory infections, mainly tracheitis, which is somewhat occurs often in patients with tracheostomies. However, invasive ventilation with a tracheostomy offers a secure airway, easier way for secretion management. And this is a big point in patients who have a lot of secretions. You can easily suction those secretions through a tracheostomy. While if the patient doesn't have a tracheostomy and they have a face mask, it may not be as easy. And generally speaking, there's less problems with leak. You don't have to use an interface like a mask. So the patient's nose and mouth are free. Their eyes are also exposed to the surrounding. And you can also provide 24/7 ventilation using invasive ventilation. So this is kind of a comparison between non-invasive and invasive ventilation in general. General indications for long-term non-invasive ventilation, like which kids would you consider as probably a candidate for non-invasive ventilation? So important point is that there is no specific diagnosis that would mandate long-term non-invasive ventilation. But it really depends on how that certain disease or that diagnosis is affecting the severity of the respiratory condition, or how bad of a respiratory failure is that disease condition causing. That degree of failure will mandate whether this patient needs long-term non-invasive ventilation and the prognosis and so forth. So in general, the indications could be something that has to do with the respiratory pump, which is like the muscles and the chest wall, such as things like neuromuscular conditions, chest wall deformities, prune billy, spinal cord injury, SMA, things like that, that affect the function of the pump or the muscles and the chest wall and the nerves. Or it could be a problem with the respiratory drive, meaning something that is central, that affects the respiratory centers in the brainstem. The typical example is congenital central hypoventilation syndrome. Also, you have high-level brain or brainstem injuries, tumors, certain metabolic disorders, and some other kind of rare causes that will alter the patient's respiratory drive. The other condition is the airway. So you can have good muscles, you can have good drive, but if the airway is not right, then air cannot reach to the lungs, and air from the lungs cannot be exhaled. And this happens like, for example, craniofacial malformations, obstructive sleep apnea. Patients with tracheomalacia will have expiratory collapse of their airway, so they can have air trapping. Bronchomalacia also is another condition where sometimes the airways is not patent and functioning well, necessitating non-invasive ventilation. And then the last one is the pulmonary parenchymal issues. So pulmonary parenchymal issues lead usually to two issues. Number one, reduced lung compliance, meaning the kid will have to use more force to take air in because their lungs are stiff. So they could be helped by non-invasive ventilation. Also, they can present problems with oxygenation, because parenchymal lung problems can affect the alveolar basement membrane, leading to issues with oxygenation. Some of the issues with oxygenation can be dealt with just by oxygen, but usually they also coexist with issues with lung compliance, hence non-invasive ventilation with or without supplemental oxygen might be needed. And example of those like the chronic lung disease of prematurity, recurrent aspiration syndrome, cystic fibrosis, and so forth. So it's also important to keep in mind that if you have a kid who has a disease entity that may affect his ability to ventilate properly, and let's say it's a progressive disease entity, let's say, for example, Duchenne muscle dystrophy, then the first to be affected is ventilation at night. So nocturnal hypoventilation will begin before daytime hypoventilation. So you can have a kid, for example, Duchenne muscle dystrophy, 14, 15 years of age. During the day, they have normal blood gases, but they have some odd complaints because they actually have hypoventilation at night. It is something you cannot really detect in clinic. You can detect by doing a sleep study with a capnography. So what are the symptoms that are associated with nocturnal hypoventilation that one should keep an eye for on such patients during a clinic visit? So you can ask them for how many times they wake up at night, if they have any nightmares, awkward sleeping positions to open their airway, night sweating, morning headaches, daytime drowsiness or daytime hyperactivity, behavioral and cognitive problems, and failure to thrive, and recurrent airway infections, and cor pulmonale, which is a late manifestation. So those things, if they are present in a certain patient who is at a particular setup for having hypoventilation, such as a parenchymal lung disease or a neuromuscular condition or a brain injury or something, and they have those issues, but you have to ask directly about them to make sure they're present or not, then this indicates that this patient is having nocturnal hypoventilation, which could be the first step towards having nocturnal and diurnal hypoventilation and respiratory failure. So long-term non-invasive ventilation in pediatrics, contraindications. So there are no absolute contraindications to long-term non-invasive ventilation in pediatrics. There are some relative contraindications, but the main ones are if the patient is unable to protect their upper airway, patency, meaning that you put the mask on and the moment the mask goes off, their upper airway will collapse and close. Then this could be a contraindication for non-invasive ventilation. Disorders of respiratory drive. A lot of people say if you have a patient, for example, with congenital central hypoventilation, where they have a disorder of the respiratory drive, and the gene, their FOX2B mutation is like showing more than 24, 25 polyanion repeat expansions, then some people will say no, you shouldn't probably non-invasively ventilate those. They should be ventilated invasively. But some cases, some people will look at it differently. But this is another relative contraindication, something to keep in mind on when choosing the candidates for non-invasive ventilation, and make sure that they have a good respiratory drive. Significant gastroesophageal reflux, cyalluria, and the excessive bulbar palsy. This all carries the risk of aspiration, and those patients are better off with a protected airway with a tracheostomy. However, keep in mind that a tracheostomy does not prevent aspiration. Even a cuff tracheostomy wouldn't really prevent the occurrence of aspiration. However, it kind of prevents sort of catastrophic episodes where the patient aspirates and suffocates and dies. Other relative contraindications includes requiring more than 16 hours per day of ventilation. So if your patient needs more than 16 hours per day of ventilation, then keeping them on non-invasive ventilation, it might be a little bit tough because you're going to have an interface on the patient's nose or mouth, and then the skin will start to degrade, and you start going into issues also that I will show in my future and in some upcoming slides. However, there are ways to go around that. You can use mouthpiece ventilation or CP valve. You can use different types of masks with different interfaces. I'll come across that to overcome this. Also, another potential contraindication is not being able to find an adequate interface. So if there's no adequate interface for that particular patient, and this is something we run across somewhat commonly in pediatrics with especially kids with genetic malformations or congenital malformations of the maxillofacial structures, it's difficult to find an adequate fit for them. And also, if you don't really trust the caregivers very well, you don't think they're very competent or compliant, then maybe invasive ventilation might be a better option. So these are like some of the things you have to keep in mind when you see a patient and trying to decide whether this patient is a good candidate for non-invasive ventilation or are they more suited for invasive ventilation. So what are the system components of non-invasive ventilation? So you, of course, have the ventilator, the interface, the expiratory system, the humidification system. So these are the four components. So we'll start with the interfaces. So you have different types of interfaces: nasal prongs mask, oronasal mask, and full face masks. Each has positives and negatives. If you talk about the nasal masks, they are usually the most commonly used. They only cover the nose, so the mouth is free, and so the patient can talk, they can eat, they can cough up sputum because they have less of dead space because they're smaller. So they're associated with less CO2 retention or less rebreathing. They are also more comfortable. And very importantly, if the patient has to vomit, then they can vomit. And this becomes a particular point in patients with neuromuscular conditions where they can't really move. So in the middle of the night, if the patient has an episode of emesis, because a lot of those patients have G tubes and they are on pump feeds and they are sometimes fed continuously through the night, so they can vomit through the night. And if they have a neuromuscular condition, they don't have the strength to take off their mask. So they're going to vomit into an oronasal mask and then they're going to aspirate. However, the issue with nasal masks is sometimes you can come across mouth leak or venting. So the pressure goes through the nose, comes out through the mouth, doesn't go to the airway, so there's no use. One way to go around this is to use something called a chin strap, which is like a strap that wraps around the chin somewhat loosely, but it kind of keeps the mouth closed. Nasal prongs are the least claustrophobic of our interfaces. However, they are not able to produce high pressures. So if the patient needs bi-level pressure, then nasal prongs may not be an option for them. Also, they're associated with a high incidence of dryness of the nasal mucosa, and that leads to ineffective ventilation. Also, if the patient is sleeping on their side, nasal prongs will dislodge, or most likely they will dislodge or get dislocated from their place. So that's another issue for nasal prongs, is that they're not very secure. So that's something to keep in mind. So these are some types of nasal masks. The first, the upper left corner, the kid in the white shirt, these are nasal prongs. The neonate in the middle in the pink dress has a nasal mask with a headgear. The 6-year-old, almost, probably 6 or 10-year-old, on the upper right side, this kid has a oronasal mask. In the United States, this is referred to as a full face mask. The bottom line, there are some interesting interfaces here. This mask on the girl with the purple shirt, this is called the Dreamweaver. So it is not a solid plastic mask. It's actually made from a fabric. And it's really easy on the skin. So it's a nice option for kids who are likely to have a lot of skin breakdown from mask or skin sensitivity. So it's very soft. The one in the middle is called a scuba mask. In the United States, they call it scuba mask. I think in the UK, they call it a total face mask. And then the bottom right corner, this is an interesting mask because it's an oronasal mask that actually saves the nasal bridge. This particular mask is called Amara View mask. There's another brand that produces masks that have the same concept. But this is one of the ways how you can actually use 24/7 non-invasive ventilation by alternating the Amara View mask, for example, with a nasal mask, for example, or an Amara View with an oronasal mask. So you can change the pressure points during the day. So system components, ventilators. So there's a lot to say about ventilators in non-invasive ventilation, but some important points I think that to mention. So the very important in pediatrics, the ventilator, the machine should be approved for the patient's age and weight. This is very important. Some machines are approved only above 10 kilos. Some are approved only above 13 kilos. Some are approved only above 30 kilos. Some machines will tell you, well, this ventilator is approved if you're going to use it for CPAP for patients above 10 kilos, but if you're going to use it for BiPAP, it's approved above 30 kilos. So that's also important to go into those nitty-gritty details about ventilator and which age they're approved for. And the importance of age and weight is you want to make sure if this ventilator is able to generate the small tidal volume that's necessary for this patient. Also, is the trigger sensitive enough for a pediatric kid or a neonate even? And is the alarm limit also, is there an alarm limit that is low enough to be useful in pediatric patients? And then pressure presets generally can compensate for leak. One issue with non-invasive ventilation is leak. And pressure presets, namely BiPAP, can, to a good degree, compensate for the presence of mask leaks. So they are much more preferred over volume presets. Modes, of course, CPAP is used primarily for OSA, BiPAP-S. It's synchronized, no backup rate. This is rarely used in pediatrics. Sometimes in teenager with severe OSA, you can use it. BiPAP-ST, this is the most commonly used mode for BiPAP ventilation. BiPAP-ST, synchronized times. So it has a backup rate. It's very commonly used in patients with neuromuscular disorders, airway obstruction, interstitial lung disease. And the settings you need to put in is the IPAP, the EPAP, I time, and rate. Make sure you have enough IPAP, EPAP difference to generate a good tidal volume. System components, the exhalation systems is somewhat confusing for some. So the exhalation component is, how does the exhalation happen? Usually, the most common type is what's called single limb passive circuit. So in this case, inhalation comes from the ventilator. Exhalation is through vents or openings in the mask itself. So it's a passive process. This offers the best synchronization. The second option is single limb with controlled exhalation valve. So you have one limb, meaning one tube going from the ventilator to the mask, but then you have an exhalation valve that is actively being controlled by the ventilator mechanism. And then you have the double limb circuit, which is the most advanced, in which you can control inspiration and expiration. And you can see two pipes from the vent to the interface. However, you can run through issues with synchronization with double limb circuits. However, they're good for hypoxic patients because they maintain a higher FiO2 than passive circuits. In pediatrics, always use humidification, because especially in patients with neuromuscular disorders, because if we don't use humidifications, their secretions will become thick, and they already are weak to handle their secretions. So it's really important to always use humidification in non-invasive ventilation in pediatrics. And when you're using humidifications, keep in mind that heated humidifiers are much more efficient than passive humidifiers. The addition of a humidifier will add to the resistance of the circuit. So that's the issue with humidifiers, is that they will add to the resistance of the circuit, and they can also reduce the sensitivity of the trigger mechanism. So this is a nice slide. This shows the coordination of care and the elements for successful home non-invasive ventilation. So first of all, you have to make sure that the patient can protect their airway, that their airways are patent, that they have a good respiratory drive. Rule out things that may interfere with non-invasive ventilation, such as reflux, sialgia, bulbar palsy, and then make sure you have a proper interface, proper ventilator on a proper mode, family is well trained and well adapted, and then you have a multidisciplinary care team. Coordination of care, it's best to start non-invasive ventilation electively, meaning when you start noticing that this patient is going down the path where they're going to require non-invasive ventilation, then rather than to wait until they go into full-fledged respiratory failure, you can start it electively and preferably during an admission. So you admit the patient to start non-invasive ventilation. One study showed that the most common barriers to discharge of patients who are on non-invasively ventilated home issues, funding, getting the equipment home, family social issues, the presence of an intercurrent illness or hospital-acquired infection, the presence of community caregivers such as home health nursing, and the last two relate to the healthcare team in the hospital and the coordination between the different facets of the healthcare system and the different professionals and how their attitude into getting the patient out of the hospital home. So these are the most common obstacles to sending patients home. Home monitoring. So if you're sending patients on non-invasive ventilation, the most important home monitor is to have an awake and an alert trained caregiver who's available 24/7 to provide first-line monitoring on non-invasive ventilated kids at home, such as mask displacement, which is the major issue, is mask displacement. Patients who have a kind of altered mental status, who don't wake up spontaneously, or they can go into respiratory failure, and they cannot breathe spontaneously to set that off. Or patients who really, if they are disconnected from the circuit, then they will go into respiratory failure or arrest. Well, number one, preferably those patients should be on invasive ventilation, not on non-invasive ventilation. But in a specific patient, if the family doesn't want a tracheostomy or you have to put them on non-invasive ventilation, then in addition to a presence of an individual to observe it 24/7, then having an external home monitor in addition to a wake and alert trained giver is mandatory. And that can be achieved through having a pulse oximeter machine or a cardiopulmonary monitor. It also can be achieved in addition through setting appropriately the ventilator alarm limits and the pulse oximeter alarm limits. This is very important. So patient follow-up, well, every patient is different, but usually the first follow-up is usually, I prefer them to be seen within a month of the start of non-invasive ventilation. And then they can be seen every 3 to 6 months. And even any modification of ventilator settings should be done supervised by a physician. And then because those patients have a number of follow-ups, then it's better to see them all, see all their follow-ups, have their oral appointments on the same day. And then they need an annual sleep study to see how things are going. So complications of non-invasive ventilation include skin ulcer, mid-facial hypoplasia, nosebleeds, eye irritation, rebreathing, gastric distension, pneumothorax, reduced cardiac output. Reduced cardiac output can happen due to increased intrapulmonary pressure and increased intrathoracic pressure, which reduces the venous return, which can affect cardiac output. So you have to be very careful when putting kids on non-invasive ventilation who have congenital heart disease. Skin ulcers, mid-face hypoplasia is an important one. So usually if the kid is really young, under 6 years, it's probably worthwhile taking a lateral skull x-ray at the beginning of the treatment and then doing every 1 year or every 6 months lateral skull x-rays to see if there's any mid-face hypoplasia, and also seeing this patient along with the plastic surgeon or maxillofacial surgeon. Nosebleeds can be reduced by humidification. Eye irritant is a function of leak. Rebreathing is a function of having a large interface. Gastric distension and GERD, these are very important because they can lead to vomiting. So if you have a patient who has a G-tube, sometimes it's a good idea to vent the G-tube during non-invasive ventilation. Then pneumothorax usually happens in kids who have an underlying lung problem, such as cystic fibrosis, for example. So the effect on family will usually vary depending on how long the treatment, how many hours a day, and if there's a home nurse or no. However, families continue to prefer non-invasive ventilation over invasive ventilation whenever possible. Family caregivers should always receive an initial and an ongoing psychological evaluation or psychosocial evaluation to see how they're doing and how they're dealing with the burden of having a non-invasively ventilated kid at home. It's also very helpful for family to have a key worker who you can communicate with to enable so that they know who to reach if they have an issue by phone or by email. And technology-enabled communication modalities such as using the internet to communicate, video and voice are recommended. So just a quick note about neuromuscular conditions. Assisted ventilation neuromuscular conditions have been shown to prolong survival in patients with Duchenne muscle dystrophy. Non-invasive is preferred in Duchenne muscle dystrophy patients over invasive. You should apply or try to or consider non-invasive ventilation if the SATs are less than 95% on room air while awake, or CO2 is more than 45 while awake, or if the sleep study shows hypoventilation, or the patient is having symptomatic dyspnea. So you can do mouthpiece ventilation and nasal mask to achieve daytime long-term non-invasive ventilation, which means 24-hour non-invasive ventilation. One study showed that if you use a PEEP of 4 to 5, delta P of 8 to 10, and an age-appropriate backup rate, then these settings will probably work for the majority of kids with neuromuscular conditions who need to be on non-invasive ventilation. Update on OSA. So long-term non-invasive ventilation for OSA, mainly CPAP. So surgical intervention, tonsillectomy adenectomy, remains the first line of treatment. CPAP is applied when you cannot do TNA, or if TNA is contraindicated, or the patient is not a candidate for surgery. The positive pressure level must be titrated through an overnight study and then reassessed every year. or whenever the symptoms change. Some emerging concepts about the use of obstructive sleep apnea in kids is the use of autotitrating CPAP, which has been used in adults for a long time, but now it's making its way through to pediatrics. Pediatric sleep physicians, we usually have some sort of apprehension from using autotitrating CPAP in kids, but it's kind of it's making its way into pediatrics. Also, there are now some studies that show that high-flow nasal cannula can be used in some kids who are intolerant of PAP, and there are some protocols to titrate high-flow nasal cannula in the sleep lab instead of titrating positive airway pressure for kids intolerant of PAP, especially in neonates and young infants. Cine MRI and OSA also has a place where it can show you exactly where the obstruction is happening, and this can help guide surgery or make decision for surgery. And patients with kyphoscoliosis, so different studies are different, but if a patient is having an FVC percent of 35 to 60%, then consider using non-invasive ventilation, especially perioperatively. In the past, tracheostomy was mandatory for patients who are undergoing spinal fusion surgery for severe kyphoscoliosis. Now it's no longer the case. However, before a patient undergoes surgery for severe kyphoscoliosis, then it's a good idea to see if they need non-invasive ventilation and to have them on it pre-surgery and right after extubation from surgery. In cystic fibrosis is also being used, especially in kids with FEV1% predicted less than 30%. Or some people say less than 50%, because those are the kids who you expect to have nocturnal hypoxemia. So they may benefit from an invasive ventilation at night after having a sleep study. In the COVID-19 pandemic, so what things happened during the pandemic, children with long-term invasive ventilation are clinically vulnerable and increased risk of respiratory failure during any viral respiratory infection, including COVID-19. However, non-invasive ventilation can generate aerosols of viral particles, which is a major risk of contamination for the caregivers. There was a tremendous increase in use of telemonitoring and video consultations to monitor those kids and avoiding the spread of disease. Using transmission of data from home ventilator, night pulse oximetry, capnography, and telephone support has been very effective in keeping those kids out of the hospital. And there has been a reduction in the number of sleep studies done for those patients. So summary point, non-invasive ventilation pediatrics is increasing in use. The availability of different types of interfaces is important in widening the use of non-invasive ventilation in pediatrics. It's important to pay attention to the component settings and the type of ventilation according to the patient and the underlying condition. And then it's very important to involve the patient, the family, and a team approach is also essential. So thank you very much. These are my references, and I'll be happy to take any questions.
Well, thank you very much, Dr. Hisham. Excellent presentation, and you did really cover most of the cases related to non-invasive ventilation for pediatrics, from neuromuscular disease to hyperventilation to obstructive sleep apnea. Thank you very much. Now, we do have a few questions. One of them, I think you did answer here, Dr. Nawal. She's asking about the role of NIV in patients with adenoids. And I think you said it clearly that first line is adenotonsillectomy. Is that true?
Yes, in pediatric patients who have obstructive sleep apnea, the first line of treatment is adenotonsillectomy. If the patient is not candidate for surgery for any reason, or if the patient undergoes surgery but they continue to have symptoms, or if the patient had a pre-operative sleep study that showed severe sleep apnea, or if the patient is of the population of a high risk of persistence of sleep apnea despite TNA, such as obese patients or patients with Down syndrome or patients with underlying neuromuscular problems or underlying craniofacial malformation, then in this group of patients, post-TNA, you do a sleep study, and if that sleep study shows persistence of sleep apnea, then you go to CPAP on those patients. But generally speaking, the first line is always tonsillectomy, adenoidectomy, generally speaking, in pediatrics.
Well, let's have another two questions here. Someone is asking about your experience with the high flow nasal concentration, and what's like, would you give it if only the NIV failed, or would you start, is there's a guideline on using the high flow nasal cannula?
Yeah, so I haven't come across a guideline for using high flow nasal cannula for obstructive sleep apnea in pediatrics. I have used it before, especially in kids under 2 months of age. And I have titrated kids on with using sleep studies. Now, the issue when you titrate a patient with high flow nasal cannula is you usually will lose the thermistor and the nasal flow signals, and you will have to rely on autosaturation, CO2, and chest and abdominal belts. But you can titrate the study. Well, it's kind of a difficult question really to answer. But I think the guideline is still to use positive airway pressure in children and not to go for high flow nasal cannula. Now, if I'm thinking that this patient, like for example, has a condition that I think is most likely going to go away in a few months, then I'm probably going to start high flow nasal cannula. For example, let's say a patient with congenital laryngomalacia, like a 2-month-old congenital laryngomalacia, having some stridor, and the sleep study shows sleep apnea. Most likely, this kid is going to grow out of it. I would probably start him on high flow nasal cannula during the night. We'll treat his reflux if he has any reflux. And then if that takes care of his stridor and his sleep apnea, I would probably keep him on that until he grows out of it. But yeah, every case will be different probably in this case.
Sure. Now, two more questions. He has a question from Samira. She's asking, what should be a normal range of oxygen saturation maintained on NIV?
So assuming the patient has normal heart, like they don't have right to left shunting, then the normal range for auto-saturation maintained the non-invasive ventilation should be the normal range of oxygen saturation, normally, which is, depending on the case, I would go for something above 94%, 95% and above. I might be okay to accept something 92 and above, but I would not really accept something below 92% in pediatrics.
Okay. And the last question is related to treating difficult to titrate with CPAP, obstructive sleep apnea, and whether it's okay to use the adult BiPAP on spontaneous mode to treat obstructive sleep apnea. They're not hypoventilating.
You can use the machines. Adult BiPAP can be used. Some of those machines have a minimum weight of 13 kilos, 13 kilos. So the machines can be used in pediatrics. And yes, like in adults, if you try CPAP and you cannot titrate the patient, their airway is not opening up to the maximum CPAP of 14, then yes, you can go to using BiPAP. And very few, but sometimes we have to titrate kids on BiPAP, namely two populations of kids, obese adolescent patients and patients with craniofacial malformations, airway malformations are the more likely kids to require BiPAP as opposed to CPAP.
Well, thank you very much, Dr. Hisham Hamdan. Excellent presentation on home non-invasive ventilation.